Hello and welcome to this session of the Center for Podiatric Education. And in this session, I'd like to talk about a subject important to all of us, and that's the role of the podiatric physician in the management of peripheral arterial disease. We certainly know as podiatric physicians that we play a major role in the diagnosis of vascular disease, but what about our role in actual treatment? And I would argue that we play a major role in treating these patients. We should be evaluating and treating them, and I believe that this should be a regular part of our practice. There's no question that as podiatric physicians, we are seeing increasing numbers of patients in particularly two categories of increased vascular disease, the first being that of the diabetic patient, and certainly the patient of increasing age, that is to say, the geriatric patient. With increasing aging, we see problems arising that we did not see with the same frequency some years ago. And we're seeing gradual deterioration in body function, which is a natural part of aging. And one of these problems is, in fact, that of peripheral arterial disease. This is really the first time in history that diseases of deterioration have replaced communicable diseases, that is to say, infections, as the major course of morbidity and mortality. We're seeing the effects of aging, we're seeing the effects of diabetes, we are seeing the effects of peripheral arterial disease, and we're seeing the effects of obesity in our practices, and it is important for all of us to gain greater familiarity with these degenerative disorders and the evaluation and treatment of these disorders. With particular reference to peripheral arterial disease, we know that peripheral arterial disease is related to aging. And as we, as podiatric physicians, are seeing patients with increasing age, we're seeing increasing incidence of patients with symptomatic and non-symptomatic peripheral arterial disease coming to our offices. We know that peripheral arterial disease is common, and the majority of patients that have peripheral arterial disease are actually asymptomatic. I have occasion to review quite a number of malpractice cases in which there are allegations of failure to detect peripheral arterial disease, and then in hindsight we have attorneys and plaintiff experts pointing to various symptoms suggesting that this should have alerted the practitioner to the presence of peripheral arterial disease. And while I think in the majority of cases that's not true, what is true is that not uncommonly we see patients who have peripheral arterial disease with atypical leg symptoms, particularly in the diabetic patient because of neuropathy, and in the older patient where the symptoms are interpreted as being associated with something else, such as spinal stenosis. Now, a recent example in my office points to this. I had a patient that I was treating for a ulceration below the right fifth metatarsal base. This patient had diabetes, he had neuropathy, and he had a cavovarus foot type, and the etiology of his ulceration was easily explained by virtue of his neuropathy, his increased weight, and the fact that he had a cavovarus foot. He developed a sudden change in the presentation of his ulcer in 1 week, and he developed a blackish necrotic eschar to the wound. This alerts me to the possibility of vascular disease. I went ahead and performed some Doppler studies, and he had very poor monophasic sounds. He was about 1.5 years post superficial femoral artery stenting on that side. He had no history of night pain. He had no history of claudication. I called his cardiologist and alerted him to the Doppler findings, and the cardiologist was a bit taken back when I said there was no claudication, there was no rest pain, and was sort of reluctant to reappoint the patient, but I urged him to do so that week. The patient was seen the following day. He did indeed have an almost total occlusion of his SFA stent. An urgent procedure was performed and the leg was saved. And my point is, this was a patient who was diabetic, had almost total occlusion of his superficial femoral artery stent, and yet had no history of claudication and no history of rest pain. And in fact, we find that in patients with significant peripheral arterial disease, claudication is really present in no more than about a third of these patients. So that it's imperative for us to consider the possibility of peripheral arterial disease in any patient who is at high risk. Now, not only are there considerations with regard to the lower extremity, but we have considerations systemically. We know, following the partner study, that there was a tremendous association between the presence of peripheral arterial disease and cardiovascular disease, renovascular disease, cerebrovascular disease. And in fact, we know that patients that have peripheral arterial disease are at greater risk for cardiovascular morbidity and mortality, and greater risk for all-cause mortality. So that when we identify the presence of peripheral arterial disease, it alerts us that we have a patient who is generally at high risk for systemic problems. And it enables us to get that referral back to that primary care physician, or if the patient is not seeing a primary care physician on a regular basis, to instruct the patient on the need to do so. So we know from a number of studies, and it's been long known, that there is an overlap, and a significant overlap in patients who have peripheral arterial disease and those that have cardiovascular disease, coronary artery disease. And if we look at the survival of patients diagnosed with peripheral arterial disease, we know that we have decreased survival in patients that have symptoms of intermittent claudication, and we certainly have decreased survival in patients who have critical limb ischemia. This makes these patients difficult. It makes them difficult to heal their wounds. It makes them difficult to heal from amputations. It makes them difficult patients to manage generally. These are challenging patients, and again, it is important to recognize these patients early on. If we look at patients with peripheral arterial disease, again, looking at the need for coronary artery revascularizations, their incidence of stroke, their incidence of carotid artery stenosis and need for interventions, their need for amputations, for peripheral revascularization, their incidence of myocardial infarction. We know that the worse their peripheral arterial disease, the greater their risk for some significant event related to cardiovascular disease to occur. Again, pointing to the need for us to screen patients for these problems and make appropriate referrals. And this is something that the podiatrist can play a critical role in doing. Similarly, as podiatrists, there's no question we have been seeing an increased number of geriatric patients, because this is reflective of the fact that the geriatric population is the largest growing segment of our population. And again, we know that if we look at geriatric patients that have peripheral arterial disease, they have a higher risk of stroke, of heart attack, of death, and all-cause mortality, both with and without symptomatology associated with their peripheral arterial disease, pointing again to the need to diagnose these patients and make appropriate referrals, but also to recognize the fact that these are going to be more difficult patients to treat. As podiatric physicians, we also are faced with the challenge of evaluating and managing patients with diabetes, and we know that diabetes is associated with increased risk of peripheral arterial disease, and again, we are seeing an increasing number of patients with diabetes as we are seeing an increased risk of geriatric associated pathology. In looking at the diabetic patient, we have been classically taught to look at patients as having, for example, either neuropathic symptoms such as neuropathic ulceration or ischemic ulceration, but we actually have many patients that have a combination of the two, and increasingly we realize that many, if not most of these ulcers, particularly distal ulcers, are neuroischemic rather than just neuropathic or just ischemic. So that even in the patient that seemingly has just significant neuropathic disease and a classic neuropathic ulceration that we can explain on the basis of a deformity or biomechanics, we still need to go ahead and assess these patients for the presence of peripheral arterial disease, because we know with aging we have an increase in the presence of both macrovascular disease as well as microvascular disease. These things can be augmented by excessive alcohol use, poor control of blood pressure, smoking, deterioration in control of the diabetes. And again, it's important to recognize that both micro and macrovascular disease occur with increasing frequency with aging. So in our diabetic patients, we have this transition, if you will, from patients that initially are demonstrating findings in their feet that are primarily neuropathic, whether it's due to motor neuropathy or sensory neuropathy or autonomic neuropathy, into a transition wherein the patients develop an increasing presence of large and small vessel disease superimposed on their pre-existing neuropathic lower extremity pathology. As a result, we see an increased risk and incidence of amputations in our diabetic patient. Now, some of this is due to the fact that even in this day and age when the role of the need for podiatric evaluation and care is established, we still see delayed presentation of patients for care. In part, this is due to neuropathy. In part, this is due to the fact that there are some primary care centers that still seem to feel that alternative healthcare providers, such as physician assistants or nurse practitioners, can evaluate the lower extremity and foot of the diabetic patient in a competent manner. I think this is clearly not the case, and it's a classic example of not knowing what it is that you don't know. There's frequently therefore a delay in diagnosis, again in part because of a muting of the symptoms due to neuropathy or a failure of the patient to seek care. There is therefore delayed treatment, and oftentimes, unfortunately, there is inadequate treatment because of a failure to recognize the role of peripheral arterial disease or the role of underlying deep infectious processes. As the podiatric physician, our first job is to obtain a proper history, including a history for the presence of signs or symptoms suggestive of peripheral arterial disease. The evaluation of the patient for peripheral arterial disease can be a low-tech, high-touch examination. Our ABIs can be obtained easily in the office for some objective screening. Doppler examination is extremely useful and indicated in many patients. I think one of the biggest issues is patient education and also active treatment of the peripheral arterial disease by the podiatric physician, and I'm going to emphasize that in our discussion today. I don't think perhaps we do enough. I think all too frequently we take the patient, obtain studies, and make a quick referral to vascular surgery and interventional cardiology, which is fine. But there are patients that don't require interventions, either vascular intervention or endovascular intervention, that we can assist with symptomatology. we certainly can assist the primary care physician, the endocrinologist, the internist in talking to our patients about the need to manage associated risk factors with the peripheral arterial disease. There's no law that says a podiatric physician can't discuss weight loss, better control of hypertension, better diet, better control of diabetes, and so forth, and obviously referral when indicated. So do all patients require Doppler examinations and ABIs? And obviously not. But if the patient has leg or foot symptoms that are suggestive of peripheral arterial disease, signs or symptoms, or they have a non-healing wound, then one should consider vascular assessment. Patients over the age of 65 have increased incidence of peripheral arterial disease and probably warrant at least screening Doppler studies. And patients over the age of 50 who have diabetes, who have a history of smoking, who have a history of risk factors associated with peripheral arterial disease, perhaps smoking, dyslipidemia, and so forth, or patients that have diseases such as diabetes, with which peripheral arterial disease is known to be associated. Now, what about the patient in whom a history of claudication is obtained? Now, obviously, we want to make sure that this is, in fact, arterial claudication. We can have neurogenic claudication from spinal stenosis. We can have claudication from venous disease. And, of course, we could have leg pain and cramping from any number of pathologies. It can be electrolyte abnormalities. It could be musculoskeletal abnormalities, arthritic disorders, and so forth. But assuming that we've evaluated the patients for these other problems, and we determine that they do in fact have vascular claudication, what happens? Well, with reference to their leg and foot, about half these patients will improve over time with appropriate therapy. About 1 in 4 patients' symptoms will stabilize, and about 1 in 4 will worsen. And of those patients who worsen, again, about 25% will require an intervention, and a small percentage will go on to amputation. Looking at the patient systemically, again, the patient who has arterial claudication, what are we looking at systemically? A significant portion of those patients will die from cardiovascular disease. Some will have a fatal non-cardiovascular event, and about half will go on to survive with no cardiovascular event whatsoever. Looking at the availability of common diagnostic studies, segmental Doppler pressures and PVRs are probably appropriate for most patients as a screening disorder, screening test rather, in patients that have signs or symptoms that you interpret as being associated with peripheral arterial disease. We want to remember there are limitations to these studies, particularly the patient with vascular calcification. More advanced testing generally is relegated to those to whom we refer, such as magnetic resonance angiography, CT angio, and so forth. What about the patients that have asymptomatic peripheral arterial disease that are coming to our office with complaints that are unrelated to their arterial supply? About 1 in 5 of patients over the age of 70, in fact, have asymptomatic peripheral arterial disease. As we've already noted, we need to step back and look at that patient, generally recognizing that they are at increased risk for mortality and cardiovascular associated events such as stroke. Therefore, we want to assure that these patients are seeing their primary care physician, are getting adequate medical care, and if not, we want to encourage them to seek medical care. There are things that we can do. We can certainly encourage the patient to exercise more, and we'll talk about the role of exercise therapy that we can enforce on patients, encourage them to utilize for treatment of claudication and prevent progression of asymptomatic peripheral arterial disease, we certainly can encourage the patients to engage in lifestyle modifications, such as losing weight and engaging in smoking cessation. And we can educate patients on the role of weight loss. We can educate patients on the need for smoking cessation. And I think it's a good idea to document the fact that the patients have been told that factors such as overweight status and smoking will affect their peripheral arterial status, and that we can lower their risk for lower extremity and systemic morbidity if they engage in proper behaviors to change their lifestyle. I think it's also a good thing to have in the note that goes back to the primary care physician. It shows them that you're looking above that foot, you're looking at the patient generally, and you're being a good healthcare provider. While it's true that we do not treat hypertension, it is true that we can inquire of patients as to whether or not they're being compliant in taking their medications for lowering their blood pressure. And certainly, the patient has peripheral arterial disease has to be more carefully evaluated and treated proactively for problems that can lead to skin breakdown and ulceration, so that the treatment of skin disorders, whether it's onychomycosis or skin cirrhosis or tinea pedis, fat pad atrophy, and deformities, particularly when they're rigid and non-yielding, need to be addressed either by accommodation or palliation or intervention. From a practice management standpoint, although this should certainly not be your consideration, but these are issues that need to be identified, addressed, and treated, and an appropriate evaluation and management code included. And when patients return, we want to assess their compliance with therapy, we want to assess their response to therapy, and we want to make appropriate changes as needed in their therapy. So again, looking at the natural history of peripheral arterial disease in the lower extremities, if we look at what we see initially, about 20 to 50% of these patients have peripheral arterial disease without symptoms. If they have a functional impairment, looking at them over 5 years, the majority, again, stabilize their claudication symptoms and don't progress. About 1 in 10 to 1 in 5 demonstrate worsening of their claudication, and about 1 in 20 to 1 in 10 have worsening disease, go on to critical limb ischemia and loss of their limb. If we look at patients that present with critical limb ischemia, their prognosis is far worse, and looking at them over 1 year, about half the patients are alive and without amputation. About 1 in 3 undergo an amputation, about 1 in 4 die. If we look at patients with typical claudication, again, their 5-year outcomes range from increased cardiovascular morbidity and mortality to stable claudication. Now, what about the patient that we see that has critical limb ischemia? What do we do with those patients that refuse an endovascular intervention, they refuse vascular surgery, or perhaps they are not candidates for vascular intervention, but are diagnosed with critical limb ischemia? What actually happens to these patients? Do we run and amputate these people? What goes on? Well, looking at several studies, the Circulace trial in particular showed that in patients with critical limb ischemia, about 13% went on to amputation in 6 months, and the most common cause for that amputation was infection. Looking at the Marston study, they noted a 19% amputation rate at 6 months, 23% amputation rate at 12 months. But notice that over half the wounds in the Marston study healed at 1 year without the need for revascularization, or the need for revascularization, but it could not be performed. so that it is not a fait accompli that critical limb ischemia means that wounds will never heal and that amputation is inevitable. The Algerzi study showed, again, 50% of patients with critical limb ischemia either healed their wounds or healed with a minor amputation. About a third of these patients went on to die, but never suffered from sepsis and went on to die for unrelated reasons with unhealed wounds. So what does that tell us? It tells us that even in the presence of critical limb ischemia, with proper accommodative and palliative care, proper local management, that we can expect, although delayed and although protracted, about 50% of the time these wounds will go on to heal. So looking at these patients, again with peripheral arterial disease, we want to encourage them to modify the risk factors which are modifiable, lowering their blood pressure, encouraging them to take better care of their diabetes, lowering their lipid profile, smoking cessation, or getting them appropriately referred to interventional cardiology, interventional radiology, vascular surgery, wherever you feel that patient would be best benefited by a referral. Now, getting specifically to the treatment of peripheral arterial disease by the podiatric physician, classic therapy historically has been the use of antiplatelet therapy, which generally podiatric physicians do not utilize. Lipid lowering therapy, again, something that the podiatrist does not do, and antihypertensive therapy, again, something that we do not do. So what are the podiatric interventions that are available? And there are a number of them. This includes exercise therapy, encouraging lifestyle modifications. It can include the use of physical therapy modalities and pharmacologic therapy. And when we make this diagnosis and recommend treatment, we generally will charge an office visit for this. We will monitor the patient's compliance, their response to therapy, the need to modify that therapy, and continue to monitor them in this manner. But we can make a substantial difference. Now, looking at exercise therapy and recommendations, if we look at recommendations of the American Cardiology Association, the American College of Cardiology rather, the Society of Vascular Surgeons, we know that for claudication, exercise is recommended as a first-line therapy. And the recommendation you should make is walking 3 times a week for 30 to 60 minutes per session, and monitor over the first 3 months to see how patients do with their intermittent claudication. Now, this can be a supervised program referred for as such, or a home-based exercise program. Have the patient walk at least 30 minutes 3 to 5 times per week. And we will document that recommendation, explain to the patient why they need to do this, and on follow-up examination, we will inquire as to whether or not they have been walking, how they're doing with that program. If the patients have undergone an intervention, a revascularization surgery, again, walking program is recommended, so that we've made our referral of that patient to vascular surgery or interventional cardiology or radiology. The patient has had their intervention done. They return back to our offices. We still want to encourage the walking and monitor the patients that, in fact, they are doing this. And we do want to assess compliance, and we want to document whether compliance has or has not been appropriate in that patient. So looking at exercise therapy, again, you're looking at 30 to 60 minutes per session. It could be on a treadmill, can be track walking, it could be outside. And again, the recommendations have been made for monitoring their progress over 3 to 6 months. Generally, there's going to be a 100 to 150% improved walking distance by enforcing an exercise program on these patients. And generally, studies have shown that claudication distance is increased, the ability to walk is increased in patients placed on a walking program. So this is certainly something that you can recommend, that you can monitor, and would be helpful for any number of patients. A second modality that you can utilize are arterial assist pumps. And all of us are familiar with intermittent sequential lymphedema pumps and compression therapy for the treatment of venous and lymphatic disease. But one can also prescribe arterial assist pumps. Generally, you want to prescribe them for use at a pressure of about 120 millimeters of mercury. You want to make sure that the inflation-deflation cycle is less than half a second. Patients are told to utilize the device 1 hour daily. It has been shown to stimulate angiogenesis in the lower extremity and increase nitric oxide levels, thereby increasing vasodilation in the lower extremities. You want to monitor, again, compliance and response to therapy and assess the patient's lower extremities to assure there's no evidence of any soft tissue injury or skin injury from the use of the device. Now, what about medications and supplements for the treatment of peripheral arterial disease? Looking at the recommendations of the Society of Vascular Surgeons, smoking cessation is critical, and again, you want to assess whether or not the patient is smoking, encourage them to discontinue smoking, document your discussion with them, and monitor their compliance in that regard. Generally, statin therapy is recommended in patients diagnosed with peripheral arterial disease. That is certainly something that the podiatric physician is not likely to utilize, although it can be done. Encouraging the patient to optimize diabetes control and certainly hypertension control is also going to be important, again, as we've mentioned, with weight loss. You can certainly prescribe aspirin for the treatment of peripheral arterial disease. Generally, the dosage is going to be a lower dosage in the range of 75 to 325 milligrams per day. Plavix, clopidogrel, is recommended for claudication at a dose of 75 milligrams per day. I think most podiatric physicians will leave the prescribing of Plavix to the cardiologist or internist. However, one of the medications that's very much underused in our profession is silostazol at a dose of 100 milligrams BID. You certainly can read online and familiarize yourself with the use of silostazol. Generally, the major contraindication is congestive heart failure, and if the patient has no congestive heart failure and there's no obvious contraindication to the use of silostazol, this is a medication that you probably should be utilizing more. It is very helpful for many patients with peripheral arterial disease and claudication in particular, and it's a safe and effective drug. You want to write that prescription. You want to monitor response to therapy, monitor for any peripheral edema, chest pain, fluid retention, or side effects from the medication. In the patient in whom silostazol is contraindicated or in whom you are uncomfortable prescribing silostazol, you can prescribe pentoxifylline at a dose of 400 milligrams 3 times a day. Again, there are many patients that will benefit from the use of this hemorrhagic agent. If you recall, pentoxifylline works by making red blood cells a bit more flexible, allowing them to get through areas of stenosis. They also have a mild vasodilatory effect. Lastly, another drug that can be utilized, although I suspect most podiatric physicians are not likely to want to utilize it, is that of ACE inhibitors such as ramipril at a dose of 10 milligrams PO daily. There are another group of agents that can be utilized, generally supplements, and these are listed here. Now, this list is taken from the American Heart Association as well as the American College of Cardiology. So there are a number of things that you could be utilizing, and we could look at them just quickly. We've talked about silostazol at a dose of 100 milligrams twice a day. Generally, again, it's not going to be utilized. In fact, it's contraindicated in heart failure. And you can have side effects that you can check for, such as diarrhea, palpitations, and dizziness, new power. Okay? We spoke about pentoxifylline. One of the things that anyone out there can utilize is arginine. Arginine is a safe supplement. It's given at a dose of 3 grams per day. Arginine is the agent that donates the nitrogen for the formation of nitric oxide. So here's a relatively safe agent without much in the way of significant side effects, although you may want to get an H&H on occasion, and a dose of 3 grams a day may be helpful for the management of claudication. Levocarnitine or L-carnitine has been shown to be helpful in some patients with claudication and peripheral arterial disease. This would be given at a dose of 1 to 2 grams daily. Ginkgo biloba at a dose of 120 to 160 milligrams per day. Another agent that you might consider is vitamin E at a dose of 50 milligrams up to 400 milligrams per day. So a number of supplements and commonly utilized agents can be prescribed safely. And here again, I would encourage you to consider using these agents. Write a prescription, and when the patient returns, ask about compliance, ask about whether or not they are benefiting. And of course, you're going to be using these agents together with other interventions. It may be an arterial assist pump. It may be the use of a walking program. Similarly, ginkgo biloba is readily available. Arginine, again, readily available and helpful for the synthesis of nitric oxide. Vitamin E, again, an agent that may be helpful in some patients and readily available. So there are a number of interventions that the podiatrist can utilize that are safe and have been shown to be effective, and of course in appropriate patients not responding to initial treatment for intermittent claudication over at least a 3-month, perhaps a 6-month period of time, you'll want to go ahead and make an appropriate referral for either endovascular or vascular intervention. Now, looking at aspirin for a minute, most studies have not favored the use of aspirin for peripheral arterial disease. However, it is a recommended pharmacologic intervention by the Society of Vascular Surgeons. Aspirin is helpful in patients who have peripheral arterial disease, who are at increased risk, therefore, for myocardial infarction, for stroke, or for other cardiovascular issues, period. So that while many trials fail to favor aspirin over other agents, it is recommended for the treatment of PAD, and in your patients that have PAD, knowing that they are at increased risk for additional cardiovascular events, you want to go ahead and recommend aspirin, generally at an 81 milligram per day dose. And this is certainly an intervention that, again, together with other interventions, may be helpful in treating the patient with peripheral arterial disease. We spoke about silostazol, again a dose of 100 milligrams BID, and pentoxifylline at a dose of 400 milligrams TID. As mentioned earlier, silostazol and pentoxifylline have both been shown to be helpful in increasing claudication distance and improving quality of life. There are other agents that can be utilized for treatment of peripheral arterial disease, Vascuprax being an example at 100 milligrams 3 times a day. However, you're going to have to monitor liver and renal function. We also want to remember that many of our diabetic patients have elevated homocysteine levels, and there are patients with primary hyperhomocystinemia. And we want to remember that homocysteine is a corrosive, it is an atherogenic agent, and many of our diabetic patients, particularly taking metformin, have lower levels of L-methylfolate, the active form of folic acid, B6 and B12. This is something that is accentuated in the diabetic patient. We want to remember that the remethylation and transsulfuration, that is to say the breakdown of homocysteine, which is a non-essential amino acid, requires adequate level of vitamin B12, B6, as well as the active form of folic acid, L-methylfolate. Metformin is associated with decreased levels of L-methylfolate, B6, and B12. It is associated with increased elevation of homocysteine. And while we know that this is a factor that increases the risk and intensity of neuropathy, it is also associated with increased risk of peripheral arterial disease. L-methylfolate is an agent which also stimulates endothelial synthesis of nitric oxide to vasodilate, and adequate levels of L-methylfolate result in increased vascularity, helping to assist in resolution of neuropathic symptoms as well as wound healing. And therefore we may recommend supplementation of diet with L-methylfolate, B6, and B12. We spoke about the fact that arginine donates the nitrogen to form nitric oxide, which then goes on to help and assist with peripheral vasodilation, so that we may want to engage in efforts to increase nitric oxide synthesis by decreasing homocysteine levels. What about referral for revascularization for claudication? There was a time when revascularizations were not indicated for intermittent claudication. We have seen a change in both the indications for vascular surgery as well as endovascular interventions. So this decision is based on the severity of the claudication and the anticipated risk versus benefit in any particular patient. But increasingly, in the aging population, we are seeing earlier efforts and interventions being made for the treatment of intermittent claudication, so that patients that have significant functional or lifestyle limiting disability are no longer caused to suffer, so that one would generally place patients through a trial of pharmacologic and physical therapy through the interventions that we have already discussed in those patients whose intermittent claudication is not improving, if they're having significant lifestyle impairments, significant pain, and we have made reasonable efforts at care through the various interventions we've discussed, and both endovascular and possibly vascular surgical interventions are needed. We do know that amputation rates are higher through certain parts of the United States, the so-called amputation belt. This is associated with increased incidence of diabetes and obesity and a number of other genetic factors. And we know that studies have shown that the amputation rate decreases based upon the availability and use of both open and endovascular interventions, so that there is no question that referral and intervention has been associated with lower rate of amputation. So is revascularization indicated? Absolutely. Is it associated with reduced amputation rate? Absolutely. And we know that in general, patients who undergo interventions have not only lower risk of amputation, but lower all-cause deaths, and this may be due to a number of factors, generally getting the patient into the healthcare system and recognizing the presence of comorbid conditions and appropriate interventions for them. There are some problems to be overcome. We know that even when recognized, bypass surgery is less effective in African American patients, Hispanics, and women. So, vascular disease is an issue, and addressing this is important by the podiatric physician. We've reviewed the facts that there are a number of interventions that are available to you as podiatric physicians. I would encourage you to get more involved in not only the diagnosis but the treatment of peripheral arterial disease. This includes direct measures that you can provide, exercise programs, the use of pharmacologic agents, the use of certain vitamins and supplements, and encouraging the patient in addition to be more compliant in management of their diabetes and their hypertension and losing weight. Thank you.